into presenter view. Can everyone see my slides like
Yep.
in full? Okay,
Yep.
perfect.
They look good.
Let's go here. Alrighty. Okay, so we're going to go over visual field and tonometry today. So we'll start with the visual field section, just kind of go into a little bit more depth on them, and then we will talk about tonometry, which is just another way to say how to check eye pressure and why we do it. So part one for visual fields here, and yeah, okay. So sorry, I thought I had changed the name on the slides, but you can just ignore that name on this one. It's still me. We're going to go over the visual fields and then we'll transition into geometry. So the question is, why do we even do visual fields? And really the goal of a visual field is to identify any loss of vision in a specific location. Most commonly in clinic, far and above the reason that we're doing visual fields is to monitor glaucoma or monitor someone who we think is suspicious for glaucoma, but maybe doesn't have any visual field changes. But other reasons that we would consider doing a visual field in clinic, somebody might have a neurologic disease like a stroke, might have retinal changes or retinal pathology. They might have something called like optic neuropathies or toxic neuropathy. Medications can kind of cause visual field changes if they cause certain damage to your optic nerve. Or they might be used for assessing a patient for like a blepharoplasty to see if it's a medical blepharoplasty. And then they can also be done to like help with like a driver's exam, just because you do need a certain amount of visual field to be able to drive. So lots of different reasons. Most commonly, it is for glaucoma. So a couple definitions here. Visual field really is defined as everything visible at a single time from one eye. So it's not binocular typically. Visual pathway is the route of visual information from the retina to the visual cortex in the brain. And so it's really it starts from the front of the eye and how does it get sent to the very back of the brain to the occipital cortex. And then a physiological blind spot. So this is an area that has an absolute scotoma. So no ability to see anything caused by the optic nerve entrance. So our optic nerves, they kind of branch into a little V pattern into our eye sockets. And that kind of where it enters the eyeball itself, there is no retina in that space. And so there's just a natural blind spot. So whenever you're testing somebody's visual field, they will have that spot missing. And such is considered the physiologic blind spot. And a decibel is a unit of brightness. So the higher the number, then that means that the stimulus is dimmer. So that means you're more sensitive to less bright stimuli. And that's great because that means that you are able to pick up kind of finer details than maybe somebody else is. So we want those numbers to be high. That's typically a good thing. Um, to continue some of the definitions here. So, scotoma is an area of reduced sensitivity to light. An absolute scotoma is an area that cannot sense light at all. So, we'll kind of show you a couple different visual fields and you'll see kind of what we mean by like an area of reduced sensitivity to light. And so sometimes that just means that that area doesn't sense light as well or requires a much brighter stimuli to sense light in that area, but they still can sense something versus an absolute scotoma is that no matter how bright of a light you shine in that space, there is nothing that's going to be detected in that spot. And then a relative scotoma, that's the first definition that I talked about. It's an area that senses like less light. The scotomas, you might hear terms like scotoma, deficit, defect. Those are all kind of interchangeable in many ways. And it's really just kind of these areas that aren't seeing light as well, aren't as good at detecting the stimuli that we show patients in a visual field test. I continue some definitions here. So there's a couple different ways that we can do visual fields. Broadly speaking, we have kinetic perimetry versus static. And kinetic, really, the word kind of implies what it means that something is moved, it's dynamic. So you're moving an object, but the brightness stays the same and the size of the object stays the same. And so, most commonly in that category, we think of Goldman perimetry, but it's not really done as frequently anymore as it used to be with kind of the invention of like the Humphrey visual field and the octopus visual field, those have certainly replaced that in the clinical setting. But a gold mine is really helpful for patients who either have a lot of difficulty doing the Humphrey visual field, where the attention is just more challenging, or if their visual field is so reduced, it's a way to kind of monitor things that maybe have more damage, where it's just harder for them to participate in like a Humphrey. And like I said, that's an object that's moving. And so they'll basically like dot out where they've detected that object in a map, and then they'll keep doing that. They'll put another dot, and then they'll connect all those dots and say, okay, this is their visual field for this object and this stimulus. And then they'll change that. And then if it's like a smaller object or a smaller stimulus, well, they probably won't be able to detect it until it's a little bit closer. And so then they'll dot all of that and connect all the lines, and then you'll kind of see what a gold mine is in a couple of slides here. But that's how kind of a gold mine typically works. For Humphrey visual field, that's typically the most common one that I've seen and I'm familiar with. But there's other companies that do visual fields. There's also like a headset visual field as well. So there's all sorts of things out there. But if you hear me say Humphrey visual field, I'm probably just talking about static perimetry. I kind of use that interchangeably, but it's technically the company of one specific one. And for static perimetry, this is that the test object is fixed, but the brightness and the size are varied. So they're, in kind of that bowl, and they are getting basically different sizes and different brightness settings shined at them, and then they're kind of noting when they're seeing that or not seeing that. So this is an example of Goldmon. As I've mentioned, they kind of connect the lines as to where patients can see, and then the different colored lines are reflective of different like either objects, or typically it's actually a different like size stimulus. The object typically stays the same, but that's kind of what the each line represents. And so, like I said, it's good for people who maybe like don't fixate as well or have a little bit more trouble with a Humphrey visual field, but you won't see this one as commonly. Couple of examples of static ones. So on my left, on my screen is the Humphrey visual field. I have my mouse over that, and then here's kind of an example of the octopus, because I don't use this one as much, or I don't use this one, and that's just the settings that I've been in, what they have available. Humphrey visual field tends to be a little bit more common, and we'll go over Humphrey visual field like map to kind of go through all those details and numbers. So a couple other types of visual fields that are available. So we have an Amsler grid, which is technically a visual field, confrontation visual field, and then perimetry, which we've just talked a little bit about. So this Esterman visual field is a visual field that is typically done for like driver's test, or like if somebody needs to like just kind of show how much of a visual field that they have. A lot of states, most of their definitions to allow somebody to drive would be based on what is their visual acuity, and then how many degrees of vision do they have. So in South Dakota, patients need a minimum of 140 degrees for driving without restrictions. And then if they're monocular, they need 70 degrees temporally and 50 degrees nasally. And so that's essentially what they need to kind of demonstrate in order for them to be considered like an unrestricted driver. And this is a good way to kind of test a little bit more of the degrees of vision rather than kind of like the minutia within. And I haven't personally worked with this one, but I know that that's traditionally what it's used for. And it can also be used for low vision testing as well. An Amsler grid, traditionally is used for macular pathology. So in the back of the retina, there's the macula, which is that center part of the vision that detects our finest, most detailed vision. And so that Amsler grid, typically you'll have patients, look at that dot and hold it about 30 centimeters away from their face. They usually, if they have a prescription in their glasses, they should be using the bottom part of the near aspect of their manifest. And they'll just kind of have them look at it. Everything should look like nice grids. If it looks wavy like the bottom, then we would call that metamorphopsia. And that typically can happen for a lot of different reasons. It can happen from epiretinal membrane, macular edema, anything that kind of distorts the macula can cause this sense of metamorphopsia. And so patients who have macular degeneration, we typically encourage them to have an Amsler grid on their refrigerator, on their bathroom mirror, have them look at that every day. And if they notice changes in those grids and have waviness, then that would be a sign for them to call, because they could be having some either bleeding or edema from their wet AMD or macular degeneration. Some people will say confrontational versus confrontation, and the question is kind of which one's correct. Technically, it's confrontation visual field. I thought this was a nice meme that they included. So this is really a screening test. And when you're documenting on a chart, it'll typically be next to like extraocular motility. Then there will be like CVF, and that just means that you're kind of testing, you're looking at them straight on, and then you're showing, different numbers of fingers in the periphery of their vision and seeing what they're able to detect. You're typically testing one eye at a time. It's really helpful for like big visual field changes. But for subtle changes, what you're monitoring with glaucoma, it's really not a substitute for imagery. And so the times that I use it and don't do visual field would be if I'm seeing a patient that's in the hospital that, we obviously can't do visual field testing there. And they're in for like a stroke and they're complaining that they've had vision changes. That's when I would normally do that. And if somebody's had a big enough stroke, then they will have something that's very detectable on their exam where, you bring in your hands are like, nope, can't see anything, can't see anything. You cross the midline, like, oh yeah, yeah, I see your hands now. And so it's something really obvious, really large. So that can be helpful in those situations, but typically if we can, we prefer to do imagery. All right. So then the two major goals of mimicry is really to detect and diagnose visual field abnormalities and then to determine progression of visual field abnormalities. So, detecting and diagnosing is that kind of first baseline test, and then progression means that we're looking at multiple tests and saying, are there changes across those tests that we're following? A little bit about the anatomy of the kind of nerve fiber layer and specifically like posterior pole with the optic nerve in the macula. So a lot of what we're following with glaucoma has to do with this nerve fiber layer. And this is a really nice diagram of, anatomically how these nerve fibers are arranged. So we have these superior radiating fibers, inferior radiating fibers, and then kind of the superior arcuate, inferior arcuate, and this papillary macular bundle. And this is true anatomic like configuration. If you were to look at this in a microscopic detail, this is how they would be arranged. And the reason that's important is glaucoma visual fields usually will respect the horizontal meridian. They can blend, but often if you have a nasal step defect, which I'll kind of show you in a couple of slides, it really does kind of respect that uh, horizontal meridian, like I mentioned. And that's because it's, typically death of a little fiber or bundle. And so as that kind of goes away, then that, death of that bundle will match like a visual field change, but it'll be opposite. So, because of how we detect information and then flip it when our brain is processing it. So, if you have damage to, for example, like your superior fibers, you're going to have visual field changes in your inferior visual field when you're taking the Humphrey visual field testing. So, it'll be opposite anatomically. The anatomic location that's being affected will be opposite as to what's represented in your visual field testing. And then, kind of along those lines, neurologic visual fields tend to respect the meridian, the vertical meridian. And so we'll kind of show you some examples of like what that should look like if you're concerned for something that's not related to the eye, but maybe posterior to the eye. That's really kind of a posterior aspect of the visual pathway. Those tend to respect a vertical meridian. And so that would make you more concerned. Hey, this is not glaucoma. Maybe it's something else that's causing these visual field changes. So keep going here. This is just kind of a brief, kind of summary is this sense that, defects are inverted. And so again, if you have damage, temporally, then you would have the visual field changes nasally, or if you have damage inferiorly, you'd have the visual field changes superiorly when you're testing. And it's just a little bit about how kind of this information is processed from the front and then translated to the retina. And then posteriorly, there's these fibers kind of make some changes after it exits the eyeball, and then that's why we map it to certain areas of the brain in the visual pathway. And I'll try to show you a couple of pictures in a few slides here. All right, so some basics kind of along this line. I think I mentioned this in the last talk, but for visual fields, the way they're oriented, it's as if the patient's looking through the paper. So if I'm holding up the paper and looking through it, then I'm looking at their right eye. So that's how it's represented. And so if it's a 24-2, it'll typically have a little point, which means it's like kind of pointing to the nose. And so if it has a point like this, and that's going to be a right visual field, you're looking through it like a piece of paper. And so this is representing the nasal aspect of their visual field and then the temporal aspect. And here is superior versus inferior aspect of their visual field. And when we say like horizontal meridian versus vertical, so this is a vertical meridian here, and this is the horizontal meridian. And as you can kind of see, this horizontal meridian kind of, you can, when we look back at our nerve fiber layer, let me see if I can go back here, you can see that there's almost like a line straight through it. So kind of think of that as corresponding line here in the visual field. It's not, perfect, but that's maybe a way to think about that. Second. Oh, lost my spot. All right. Okay, so different types of protocols that you can use in visual field testing. There's, a full threshold. There's C to standard, C to fast, C to faster. The faster you get, the less, the fewer points that you're testing. And so the less helpful it can be to detect small, subtle changes. But faster testing is also helpful for screening. If you're just trying to grossly say, hey, does someone have changes that we're concerned about? Yes, no. The fast testing can be very helpful for that. But when you're trying to follow someone over time and understand, well, are we having progression, kind of more subtle signs that things are getting worse, then using something that's maybe a little less fast can be helpful in those situations. So just to give you a sense, C to standard takes about 8 to 10 minutes. C to fast is about 3 to 5 minutes, and then full threshold is like more than 10 minutes. So it can be pretty, varied for the patients in terms of how long it takes. And so just, trying to be thoughtful of, what do we really need here? How many points do we actually need to test? And what is the question that we're asking here? And this is just a picture of another visual field option. This is the headset that I kind of had mentioned earlier. I've heard good things about it. I don't have any personal experience using it, but I have heard that it's really helpful for patients who have like mobility problems, have a hard time kind of sitting at the Humphrey visual field for whatever reason, and they're wheelchair bound or have neck problems. This is a good alternative for those patients. And I've heard it's pretty comparable and represents the data in a nice way that's similar to what we're used to. So I've heard good things. I don't know if anybody on here has experience using it. But yeah, that's just another way to do visual field testing. So talk a little bit about Humphrey visual field specifically. So kind of orienting you to this map here, and we'll kind of go through each parts of this paper so that when you see it, you can kind of get a sense of, okay, what are we looking for? What information is important to us? So you always want to check name and date of birth. That's always helpful. Want to make sure that you're looking at the correct patient. And then, if you're kind of recommending medicines or a surgical or procedural plan, we want to make sure it's on that right patient. So if something looks really different from one visual field to the next, that's something that we always want to make sure that that name and date of birth is the same. And then the type of test is usually displayed on this map. And I'll show you here. Up in my upper left-hand corner, typically there will be a couple of numbers. And so these are all reliability numbers or indices. And we use this to really get a sense of, is this a test that we like? Do we think the patient did well on it and is accurate? Or is this a test that is not that accurate? And if we were to recheck this again next time the patient's here, would we get a different response? And so we want to make sure that we're making decisions on accurate data. And the data is only as good as the person who's entering it, which is the patient. And so a couple of things that we look at are fixation losses. I kind of went over this a little bit last time as well, but really fixation losses are representative of if the patient, it tests their physiologic blind spot. So that's that. Let me see if I can show you with my mouse here. This right here is a physiologic blind spot. And so they would not expect to see anything there. Again, that's where the optic nerve inserts into the eyeball. There's no retina there. And so if we're flashing stimuli in that physiologic blind spot and the patient's clicking it, that means that they're not looking where they're supposed to be looking because they're detecting light that they really shouldn't be. And so that's how we, know if the patient's been looking around. So we typically don't want that to be super high. False positive errors means that a patient's really trigger happy. They're just going to click and click and click and click. And so their visual field might look better than what it actually is. And of the indicators that we look at, the false positive is the one that is most predictive of reliability. So if false positives are really off and everything else looks okay, then I'm still very suspicious of the test. And then false negatives just means that the patient was probably sleeping or just having a hard time keeping focus. And that just means that the patient is not saying that they're seeing things that we know that they have. It's almost like shining a brighter stimulus in a place that they've said, yeah, I can see it. If we shine something brighter, they should certainly be able to see it. And so if they don't click it that they've seen it, that's a little suspicious because we've like, hey, we've tested that spot. We know that you could see something that was dimmer at that point. So why aren't you clicking it anymore? And so that's how that false negative number goes up. And then you'll see kind of how long the test lasted. And then the phobia threshold just, well, there's a certain number that's associated as to kind of like what decibel like the somebody is able to like detect something. And so the lower the phobia threshold, sometimes the more concerned we are that there's just kind of some ongoing damage as well. So it's another number that we can follow. And then at the very top here, I know I'm going to just actually go back here at the very top. So we'll have a stimulus. Most of the time, the stimulus is 3. Sometimes if the patient really needs like a really big stimulus, we'll change that if they have like significant loss. But usually you're going to see the number 3 there, and then the kind of strategy that's used or the standard or the type of testing protocol that was used. These are very, very, very rigorous and studied very well. So that's, it'll indicate what is being used there. And then for this first map up here, we're going to look at the numeric grid here. So these are those decibel numbers that I mentioned that the higher the number, the better. That means that you are able to, kind of detect like more subtle things, the higher the number. And so you can kind of see this number 8 right here, and that corresponds to this dark spot, and that's our physiologic blind spot. And so, it really honestly should be 0, but low numbers in that area are totally normal. And this numeric plot or grid gets translated into this grayscale because it's a little bit easier to interpret than all these numbers. And so this is intended to show us, okay, when we shine these different levels of light, what kind of brightness or dimness do we need to show the patient to detect something? Okay, based on those numbers, now we'll translate it to a grayscale plot so that it's just easy to look at and say, oh, there's more darkness there. Then we're knowing that a patient's not able to see as well in that area. And then kind of moving along down here, there's a total deviation plot. So this is kind of takes this data up here and standardizes it for the patient's like age and kind of demographic to show like, oh, does this kind of make sense? We expect some changes over time. So if we compare it to other 70-year-olds, is your testing like reasonable for that age range, or like, are you really having a much harder time than the average 7-year-old? And then this pattern deviation normalizes data within yourself. So if you have a cataract and overall you're requiring much stronger stimulus to see something, then it kind of takes that like noise out of the picture and then readjusts that data for the patient. And then program types. So this is kind of indicating how many degrees are tested. So like a 30-2 or a 60-2 test many more degrees of vision than a 10-2. A 10-2 is really testing mostly like your macula. And the reason we would use a 10-2 is if a patient has lost so much visual field that it looks so black when you're looking at it that you're like, I'm not even sure if there's any changes from one test to another test. The data is like too zoomed out. Then you can switch to 10-2 and see, okay, now I'm able to detect more subtle changes in this very center vision that this patient only has left. And so it can be helpful in those patients who have more end-stage glaucoma to follow a 10-2 or alternate it with a 10-2 and 24-2 to find those subtle changes with time. 30-2 is like a good test for like screening, for example, when you're testing just more broadly, like, hey, is anything generally missing? Here's a bigger visual field that we're testing. I would say you're probably most used to seeing 24-2s. And like I said, that little kind of pointing at the nose. That's how I typically will quickly know it's a 24-2, but you can always look at the top too. All right, oops, sorry about that. Let me go back to my slideshow. Hmm. All right, so this is a little nice feature of Humphrey Visual Field. So this is guided progression analysis, and it's great because it kind of pulls all the data and allows us to kind of scan through it and like see, hey, is there anything that we should be concerned about here? Is there a pattern? Is it real? Or are we just having some intertesting variability that's normal? So you can kind of see that this patient's visual field almost looks like it's a little bit all over the place. The earlier ones here are to my left on my screen. And then I'm moving my mouse over to the kind of ones that are a little bit more recent. What you do see is that kind of these center changes or depressions are kept through all of them, but the amount of changes that are here around the nose is variable. Like here in 2013, they have a lot of points that they're missing, but then when you're looking here in 2014, there's less points that they're missing. And so what this analysis does is it takes this information and kind of will put little symbols next to areas where it says like, yeah, this has consistently been demonstrated from test to test. And we're pretty confident that this is like a real depression or deficit that the patient has. And then it'll kind of flag other ones that we're like, hey, this is concerning that this might be real, but we just don't have enough information yet, or we're a little less confident that this is a real depression. So kind of this triangle here, this is telling us like this is probably a real change that this patient has had and has demonstrated over multiple visual fields there. And then the other nice thing that we can look at with this is there's like a little kind of plot here. And that plot will show us just on average, is the trend that things are getting worse or things staying the same, just kind of big picture. And that's a nice thing to follow to say, hey, this slope is getting worse. And so we feel like the patient is having changes. So these are all nice features to follow somebody over time rather than to kind of looking at one and trying to like store it in your memory, try to figure out what it looks like, and then kind of comparing it to others. This is a really nice summary plot that Humphrey Visual Fields has. And I think, a couple other things that we look at to just make sure that these tests that we're following are reliable is we've talked about, whether the data is trustworthy. So all those indices that we look at, we typically will follow a few tests. And often if we see a change from one test to another, we'll repeat it and we'll say, is this real? Let's follow it. If it demonstrates itself over and over, then we say, okay, yeah, that's a real change. And then does what we're seeing make sense? So, someone who has 0.2 nerves that look healthy, have no pallor, their OCT looks full, and they're testing 20/20, but really did poorly on a visual field. That doesn't make a lot of sense to us. There's nothing that indicates that their visual field should be that poor compared to everything else that we're seeing. So you kind of have to put visual fields in the context of the clinical picture to make sure, yeah, this does make sense. And then for glaucoma, I think one thing that's really helpful, we follow it with OCT RNFL and visual field changes. So for an OCT RNFL, the traditional pattern is polar thinning. And so if you have polar thinning, let's say you have really bad superior thinning, well, I expect to see inferior changes on my visual field. And if I don't see that corresponding change, then that makes me wonder, well, is this a real change on my visual field, or is this maybe more kind of a testing variability? So that's kind of another thing that we use to confirm whether this data is true or not. So, visual fields, like I said, can be variable. It's humans taking them, and humans aren't perfect. Because some studies have shown, 86% of tests were not confirmable on a retest. So that just kind of shows that there is variability. And so that's why typically we will do a couple of tests to make sure that something is real for a patient. Some things that can influence artifact, in addition to some of the other things I've talked about, like patient attention or nervousness, things like that. Other things that can make the visual fields less reliable, how big the pupil is. If it's a really small pupil, it's going to create a lot of depressions. The patient has a refractive error, that's really significant. Dirty contacts, wrong patient, dryness, if the eyelids are really droopy, if they have a rim artifact where they're not close enough to the lens for the Humphrey visual field, they have cataract or retinal disease. These are all things, or a corneal scar, really all things that can affect how somebody performs on a visual field. Here's an example of like trying to illustrate what a lens rim artifact is. So in this picture here, the patient's a little bit further back from the lens. and they're having all these changes on the edge here. That's suspicious for a rim artifact because usually that's not a pattern for glaucoma. And so that makes us wonder, yeah, was this patient maybe not close enough, or were their lids in the way during the test? So here's just kind of some examples of what mild glaucoma would look like on a visual field. And so things that we'll look at in addition to all the points that I've pointed out, the mean deviation. And so this mean deviation, I'm not going to go through all the exact definitions, but typically if it's less than 6, we'll call it mild. And then, essentially that's kind of like one of the number that we'll look at in addition to like OCTR and FL changes to kind of define something here. Moderate, this is a great example of moderate. So you kind of see that inferior change here. Glaucoma, I'll take a second to describe, typically will either have nasal step defects. So it'll either be like a change right here near the nose, inferior, superior, or we'll have an inferior or superior arcuate. Those are the early changes that happen. As glaucoma gets more advanced, it'll start having much denser defects, and I'll show you on the next slide. But this is what we would describe as an inferior arcuate. And it probably has a little bit of an early nasal step here inferiorly as well. I mean, it does based on this plot here. And then this is just kind of like the physiologic blind spot right there. But so that's an inferior arcuate that you're seeing there, and that's kind of evidence of moderate glaucoma. And then severe glaucoma, great example here. So this is what we would call like a superior, like dead superior arcuate. And if we go back to the anatomical kind of overview of the RNFL and how it's separated horizontally by, like just in terms of how the nerve fiber layers radiate from the optic nerve, you can kind of see how this pattern follows that it represents a horizontal meridian, like I mentioned. So this pattern of like, hey, it doesn't seem to cross this middle line here, very classic for glaucoma, versus if I had something that didn't cross this vertical line here, that makes me more concerned for a neurologic problem. And then things that are very central only can be glaucoma. If it's glaucoma, it's typically like normal tension glaucoma, but it can also be toxic changes to the macula from medications, from nutritional problems. So a central defect, a little bit less common with glaucoma. So it makes you kind of think of, hey, are we missing something else in this picture? This is like a good kind of visualization of like what progression for glaucoma in this patient looked like, kind of had a tiny little change near the nose, and then that change became a little bit denser. That change continued and spread as a superior arcuate. Then it filled in, and now we have a really dense nasal step with an extension of the arcuate here. And now we have a very dense superior arcuate. And unfortunately, in this advanced case, now the inferior nasal step defect is starting to fill in. You can kind of see it there and a little bit there. And really, they've lost a significant amount of vision. So they just have what we call now basically a central island. I'm not quite ready to call it a central island because they have all of this as well. That's probably still working for them. But if this was the only thing that was left, then I would say that's central island of vision. This is a patient that might be nice to start testing 10-2 on. All right. So a little picture of, how visual information translates from the front of the eye to the back. So here's our eyeball, retina, goes to the retina, kind of gets basically, sent back here. These nasal fiber cross over and the temporal fibers of this eye stay. And then it goes here, then they split from top to bottom in this area, and then go to the visual cortex in the occipital lobe back here. Based on changes that you're having all along this pathway, they actually correspond to visual field defects. And one of the things, it's a little technical, and I won't go into too much detail, but it is important to note that, at the chiasm, the nerves from one eye cross over and join the other eye. And so that's why you can kind of get certain patterns that are very specific and localized to certain areas. So I love this drawing. Because, sometimes you just need a reference of like, hey, if I see a visual field like this, where do I think it's going to be? And you can kind of think through it, but this is a nice reference as well. So, if you have damage, so this is labeled as 1, 2, 3, 4, 5, 6. So if you have damage right here in this spot number 1, that's in the, optic nerve here of the right eye. So that's going to just, if the patient's taking a visual field test, they're going to have total blocking out of that area because that whole, basically information that's translated to optic nerve has been affected. If something happens at the optic chiasm, because of how these nerve fibers cross over, you get something called a bitemporal hemianopia. And so you can kind of see that on the temporal sides of their vision, they are not able to see. And I've seen this in the hospital. I've seen this in patients in clinic where tumors have been detected because of these visual field changes where a patient can't see on the edges. And so that's what we call bitemporal hemianopia. So usually like a pituitary tumor is something that would cause a kind of visual field. Once it gets past here, if we have a lesion back over here in 3, because now we have nerve fibers from both sides of the eye, we start having those fibers in the optic chiasm, but in the optic tract, then if we have a lesion here, then the lesion will affect both eyes and the same side. So we'll, call this like a left hemianopia, for example. If it gets a little bit further back, now you're going to get a quadrant because it's split out even further. And then depending on how far back it goes, sometimes you can spare parts of the macula because it has collateral circulation. But if you were to if you were to Google like visual field of optic, tract lesion or an optic chiasm lesion or optic nerve, you would find Humphrey visual fields that almost look identical to this, which is really fascinating to kind of see the real world version of that. All right, let me get back to my little note here. Okay, so there are many things that matter in glaucoma. And, glaucoma is very complex. The way that we define it is it's an optic neuropathy, which means, it's just something that's damaging the optic nerve. Lots of things affect it, genetics, family history, trauma, so many things can affect it. What we know that has been studied extensively is that lowering pressure reduces the risk of glaucoma getting worse. But pressure itself does not cause glaucoma all the time because some people tolerate very high pressures of glaucoma. Dr. Bertle has done a lot of research in this, and I think his theory very innovative, and I think it's starting to be, really kind of become one of the leading theories of like what happens with glaucoma. And it's actually an imbalance of eye pressure and CSF pressure. And so that's why people who have really high pressures, it can kind of explain people who have had high pressures their whole life, they never get glaucoma, probably because they have some protective pressures in their CSF that are counteracting that. But anyway, it's a complex disease with, we're still trying to understand it and learn it, but we know that lowering the pressure is productive. So unfortunately, visual field changes occur late. So we would love to find patients before they start getting visual field changes. So really kind of the early indicators of, hey, we're concerned that someone's starting to maybe have a type of glaucoma, or should we look into this further, is looking at someone's eye pressure. And so for eye pressure, it really is like a trigger for us to say we should screen this person for glaucoma. They might not have glaucoma. They might just have high pressures, and we just call that ocular hypertension. They have no damage, but we should probably look at it if they do. And so this part of the talk will focus on pressures and like why it's important to monitor them. Here's like a little bell curve of where, if you were to sample just a general population for their pressures, where it would fall. So you can kind of see that this is a curve that's a little bit right skewed. So you have kind of more patients here and a longer tail here on the right than you do on the left. And, we say that like normal pressure is 21. That really depends on the patient. But I think it's a fair, general range to use for someone if you don't have any other data about them, just saying like normal range 10 to 21, average tends to be 15. But you have all these people who live in these high pressures. And kind of this graph shows you that there's a lot of people who have these high pressures that don't have any damage to their optic nerve. And then there are some that do. And it's a little bit, you're a little more likely to have damage at higher pressures, but it's not a guarantee. You might have other protective factors that we just don't fully understand. So some patients will ask, well, what should my pressure be? And that's a little bit of a complicated answer. If it's somebody healthy that I don't have a lot of history on, not concerned that they have glaucoma, I usually say, hey, for the average person walking down the street, we'll say 21, but I do customize that answer if you have any concern for glaucoma based on your testing or if you have a family history. And the target range really just depends on how advanced is your glaucoma. How high were your pressures when you were having progression or changes? And are there other risk factors that we should be concerned about? If you tell me that your grandma went blind when she was 35 from glaucoma, I'm going to be a much more aggressive at treating your glaucoma versus someone who has no family history and has no changes on their visual field, has a great healthy looking nerve, but their pressures are 23. I'll probably just watch that. So I think you really have to kind of take everything into consideration when you're deciding how aggressive and what you want to treat for a patient. Some patients will also say like, "Hey, my pressure was better yesterday at my other doctor's office," or "My pressure was better yet, like when I came here last time." And pressure is a dynamic thing. We are taking a dynamic concept and making it static by just checking one pressure point. And this kind of graph is really intended to show that depending on the time of day when we're checking pressures, that can vary your pressure cycle. So it really can depend on like, are they valsalving? Are they bearing down? What time of day it is? What medications have they taken? All of these things can affect your pressure. And so, fluctuations are common, just like if you were to check a blood pressure on a patient that just ran up the stairs, that would certainly be different on someone who's just kind of sitting calmly. So, the eye pressure can be very dynamic as well. So, unfortunately, a very difficult glaucoma to treat is normal tension glaucoma. And what that means is that they're having normal pressures, but they're still having damage to their optic nerve. And so some patients will say, well, if my pressure is normal, then how can I have glaucoma? And again, it's just this likely imbalance between their eye pressure and their CSF, that there is just an imbalance that even though their pressure is normal, it still is higher than their CSF and can kind of cause um, some glaucomatous changes there. Here is the Baltimore Eye Study, just kind of showing that, the prevalence of primary open angle glaucoma in different like pressure brackets. And so you can see that patients who had a pressure of less than 15 still can get primary open angle glaucoma. And it goes up as pressure goes up, but basically demonstrating like, hey, people with normal pressures will get glaucoma. It's called normal tension glaucoma. It's hard to treat, unfortunately. And it just makes it a little bit scary because this means that people who will look at will check their pressures and they look normal and we don't think about it. But again, that's why when we're seeing patients, we want to look at their optic nerve. Does it look cupped? Are we concerned? That's why we take all this information and kind of make a decision about the patient. And so this is kind of going over some of those factors. So family history, we're looking at the optic nerve. Like this is what we consider a cupped optic nerve. It's too big. So 0.5 or less is what we would consider healthy. And this is like 0.7. And there's too much white in that picture there. And then the OCT RNFL, we'll look at that. It gives us microscopic views of that retinal nerve fiber layer, kind of those radiations that I kind of showed earlier. And again, that polar thinning pattern where it's red in the top and bottom like an hourglass, very classic for glaucoma. And then we'll look at their visual fields. So those are all the things that we put together to decide, hey, should we be concerned about someone? This is kind of to my earlier point that they've studied this extensively, and really what we have come to a conclusion as a medical community is reducing pressure matters. It's protective and it's important. The EMGT study basically showed that for every millimeter of mercury reduction in IOP, it reduced the risk of disease progression by 10%. So that's why I think you see a lot of specialists fight hard, for 1 to 2 points, because it does make a difference for patients that need it. Not everybody needs that kind of level of granular management, but some patients do, and it really does make a difference in terms of stopping their or slowing down their progression of glaucoma. And I think that's kind of something that I'll just take a quick detour for just a second. I always tell patients when I diagnose them with glaucoma, hey, this is a chronic disease. It's a disease that will affect your vision before you realize it. And so that's why we want to do intensive monitoring, because we want to catch it and slow it down and stop it before it affects your central vision. Because once those changes happen, they are permanent. We can't reverse them. And so really, it's kind of thinking about it as a chronic disease that we're trying to slow down. There's no cure, unfortunately. And so all our therapy is aimed for risk reduction, slowing things down. And so this is just basically kind of a timeline of like the different therapies you can offer patients at different points in their journey. And this is not perfect. You might see some exceptions in your clinic and workflow and things like that. But just kind of overall, when you're thinking about it, for somebody who has mild disease or just has high pressures and no disease, they can be great candidates for SLT or DSLT, a laser to kind of treat the trabecular meshwork. And then as they maybe develop a little bit more disease. Maybe they need some drops or some basically therapy, like actual medication on board. And so you can think of something like a Durista or an iDose. And these are great options for patients who don't want to be on drops. Or really, I mean, drops have a lot of harm. They have side effects and they can cause a lot of dryness, a lot of other things. And so really these implantable medicines are great because it's really delivering medicine at the site that it needs to be delivered at. So that's a great option for patients. And then you can move on to kind of more invasive things like eye stents or hydrus. And these are just really kind of working in the angle in a minimally invasive way, either with or without cataract surgery. And then as you go along, maybe you need something a little bit more that gives you more pressure reduction. And that would be something like a Zen or a diode. And then, as you go further along and patients who have extremely severe glaucoma or really need significant pressure reduction, then you consider something like a trab or a tube. And so that's a little bit of the journey of like, why do patients get all these surgeries and treatments done? One, it's chronic. And so we're always fighting this chronic disease. And two, as glaucoma progresses, it's less tolerant of high pressures. And so we have to be more aggressive with our treatment. It's always that risk benefit balance that we're trying to figure out is, hey, do we think the surgery is going to give enough benefit? And is it okay that this is maybe a riskier surgery? So something like a trab is a riskier surgery. It's a very effective surgery, but it's riskier, much riskier than doing a laser, for example, which is extremely low risk, very, very well tolerated. So the more that we can do kind of in this side, the better and the less risky it is for the patient. And of course, drops can be kind of sprinkled out throughout their whole therapy or treatment course. So lots of things can influence, and I'm going to speed it up here just so that we can kind of end on time, but lots of things can influence intraocular pressure. Um, Pachymetry, if a patient has had LASIK, what time of day you're checking it, if they're on medications, if they're stressed out, if they're bearing down, their body habitus, and if their posture, if they have like a really tight necktie, that can all cause pressure fluctuations and pressures to be less accurate. So a little bit about chemistry. This is really important. Basically, IOP without an understanding of their pachymetry kind of means nothing. The way to think about it is if you were to kick a tire and the tire didn't have like a lot of pressure, it would like if it's a very thin tire, it's going to indent really easily versus like a thick road tire, you're going to really have to kick it really hard for any indentation to happen. So it's kind of how to think about it. So if somebody has a very thin, you know, tire, we actually might be underestimating their pressures versus somebody has a super thick tire. We're like really jamming on that tire to get any kind of response to it. And so we might be over estimating how high their pressure is because we're having to like do a lot to get a response. And so it helps us understand, well, what's someone's corneal thickness and how to put that IOP into context of their corneal thickness. Because we know that, normal corneas, we'll know what their, pressure is probably pretty equivalent. But if they have very thin corneas, like I said, we underestimate. And if they have very thick corneas, we tend to overestimate. So again, somebody who has like corneas of 650, but their pressure is like 28, I'm not that concerned because we know they have thick corneas. And so it's probably realistically lower than what we're measuring. Lots of different ways we can measure it. Obviously, here's a couple pictures. So we have eye care, we have a tono pen, we have Goldmon, and we have so lots of nice things here. So this is just a picture of Goldmon applanation. This is something that technicians can do and do really well. Just kind of depends on the setting and the practice that you're in, but it's a great skill. It's fun to do for patients and it's really, really helpful in kind of taking care of patients with glaucoma. So applanation, we'll kind of talk about how to do it, but basically you put in a drop of proparacaine, put in a fluorescein drop as well, and then you'll use that Goldmon applanator to line it up with the cornea, and then you'll see kind of these little, this is a great example like what you would see in your view here in the blue when you're actually looking through your like oculars. And so you want these things to be touching on the inside like this. If they are not touching, then it either is that you're too low or too high. And so you need to make adjustments on your pressure knob to bring it either in closer together or further away. And so once you kind of have it lined up like this, you're just right. If you're seeing a little bit more of this and less of that, then that tells you that you're a little too high or too low. So that just tells you got to go up or down. And then again, how this aligns on the inside will just tell you if you need to change your pressures here. All right. And so some tips, we talked about anesthetizing the eye, using a fluorescein strip. Have the patient, I have them actually look right at the blue light. I'll just say, hey, keep looking at that blue light. And then you just kind of, I usually will kind of watch myself get close to it. Once I feel like I'm pretty close, then I'll get into the oculars and then just gently push forward until I start seeing those menisci. And then if I see them kind of come together, I'm like, okay, that's my pressure. And then I'll just kind of move the knob until I feel like I have it aligned correctly. Oh yeah, and then just make sure you're not putting pressure on the eyes when you're doing that. So I'll like lift their lids, but rest it on their bone here because then I know I'm not pushing on the eyeball itself. And when you're practicing early on, you can always confirm with another instrument. So if you're like, oh, or confirm with somebody else, have somebody else double check your pressures. Aura is another way to check pressures. So Aura tries to take pressures and kind of put them in the context of corneal hysteresis, a little bit kind of that concept of like kicking, a thin tire versus like a thick tire. It's along those lines of like how much rebound is there on an eye, and how does that affect our interpretation of those measurements. So I'm going a little fast here. So here's eye care. And this is like no anesthesia. No anesthesia is needed for that. Patients are typically really comfortable. For this tono pen, patients do need anesthesia. They're both fine. I would say eye care. I've used both a lot. Eye care is more reliable, and what I've seen. It matches more closely applanation measurements, but technically applanation is the gold standard for measuring pressures for patients. And then there's something called home IOP monitoring. And that's great for patients who maybe are spiking at home and we don't detect them in clinic. We can kind of measure their pressures over time and map that. And that's really helpful to see, oh, these patients are having really, really high pressures at night. And that's what's driving maybe their changes in their testing. And there's new technology coming down the pipeline with continuous IOP monitoring. And I haven't seen any of these used in practice actively, but I think the future is bright for sure in finding ways to monitor pressures continuously for patients. So I think kind of takeaways, the accuracy of intraocular pressure is really important. The pressure is only part of the story. You can't really interpret a pressure without corneal thickness. And really anybody can do applanation. It's a great skill. If you ever want to like learn and I work with you, just let me know and I'm happy to teach you. Can make a great difference in certain glaucoma clinics that use this kind of constantly and consistently for patient care. That's it from me. That is not my email address, so I apologize, but I'll include it on the next time I share some slides. But yeah, anything else I can do for y'all? Any questions? I know we're like right at the end with 2 minutes left, so I apologize.
This was so great. It's always a lot to go over when it comes to glaucoma, but such good stuff. So thank you so much.
Of course.
There was two questions in the chat. One asking how low was too low.
Yeah.
Did you already get that one?
Yep, I see that there.
Okay.
So I haven't covered that, but it really again kind of like how high is too high. Some people can have high pressures and nothing happens, and we just kind of take that in the clinical picture. Same with like, how low is too low. Patients who get Zens, for example, typically will have a pressure of 3 after surgery, like the day after, as long as their chamber is deep. They're not having any significant corneal edema or what we call choroidals, then that's okay. They're tolerating that pressure. Sometimes people have a pressure of 3, but have, like I said, a chamber that's flat, choroidals, can get suprachoroidal hemorrhages. So if they have clinical findings that correlate with this low pressure, then that makes us concerned that we need to treat this low pressure, and we'll sometimes put visco in the eye or something to kind of help increase the pressure artificially to stop some of the processes that are happening. But yeah, it's a little bit dependent on the clinical picture. But I would say I haven't seen those problems in patients who have like pressures of higher than 5. So it's usually like 5 or lower if you're going to get problems. But not everybody with pressures of lower than 5 have problems.
Awesome. Amazing. Another
And then,
great week. Oh, was there
yeah,
one more?
I think there's one more. Normal tension
Okay.
glaucoma is that a patient has a weaker optic nerve in the back of the eye tissue, therefore is it more easy damage? So that's a really good question. I think the leading theory is more that there's an imbalance between the eye pressure inside the eye and the cerebral spinal fluid that coats the optic nerve behind it when it inserts it. And so if there's more pressure, even if it's lower normal for us compared to what's coating their nerve, then it can damage that optic nerve a little bit more. And really what we think is that axonal transport is not allowed to happen as easily. And so that axonal transport is interrupted by that pressure differential. And so it doesn't get the nutrients it needs. And so those axons die and the retinal nerve fiber layer starts dropping out. So it's that imbalance. And so when we measure the pressure, we're just getting a normal pressure. But if we had more data to say, okay, this is their pressure, and then this is their CSF pressure, I think that would tell a more interesting story about these patients with normal tension glaucoma. And that's really a lot of Dr. Birdall's research is around that. The goggles that he's designed for patients to wear at night to lower their eye pressure is kind of really started from that like theory of imbalance. And I think that makes a lot of sense because for a long time, people couldn't understand why do people get glaucoma who have normal pressures. It just doesn't make sense. But it's, I think, thinking of glaucoma as an imbalance between pressures of two pressure systems, that kind of helps us understand that a little bit more.
Yeah, that is so amazing.
All right.
The
Okay. Thank
advancement.
y'all.
Yeah, thank you so much, and we
Yep.
will see you next week. Have a
All
great
right.
rest of your week, everybody.
See y'all. Have a great night.